All right, so let's talk about endotracheal intubation and mechanical ventilation. All of this is going to focus on an adult population because we are more likely to intubate adults, and we will be going to clinical taking care of adult populations. So, indications. There really are reasons we intubate patients, and the one of those is to establish an airway because they need help breathing. We can do it to assist in secretion removal. So this is somebody who is having a difficult time coughing up all of their secretions. Prevent aspiration. This makes me think of somebody who is at risk for aspiration, so they're not awake and alert enough to do that. Maybe a stroke patient who's at risk. Stroke patients may also have trouble maintaining their secretions as well, and we do it to provide mechanical ventilation. So your notes have some good guidelines to kind of follow as to why we might intubate somebody. Certainly we're going to have signs and symptoms of respiratory distress. So we'll have tachypnea. We could have bradypnea, so breathing very slowly. I don't love tachypnea, but if I have a patient that's breathing 10 times a minute, slowing down, breathing 8 times a minute, that in some way scares me way more because my thought is they are about to not breathe. They're just about to quit breathing for me. If a patient's tachypnic, sometimes that's enough to maintain them for a while, but they will get tired and worn out, and that is where we want to be proactive with intubation and not let them get tired and worn out where we're having to do this in case of an emergency. Increased work of breathing, shallow breathing, can be decreased tidal volume, which is how big a breath they take. So if they're not breathing very deeply, so having shallow respirations, showing dyspnea, use of accessory muscles, abdominal breathing, decreasing O2 sats. And then when we look at an ABG, their PaO2 is less than 60, and they're on at least 50% oxygen. So your notes do talk about an FiO2, that's fraction of inspired oxygen. So on a ventilator, we talk about it as an FiO2. And so 50% would be actually written as 0.5. So that's how that is in your notes. It's just they got to do it differently. Your PaCO2 is greater than 50. Your pH is less than 7.25. And certainly the higher your PaCO2 is, the lower your pH is going to be. So those are just some good guidelines to look at and say, you know what, this patient needs to be intubated. I have one more thought about establishing an airway, which we will talk about. You've had some last semester, we'll talk about later on this semester, is patients who are having an anaphylactic reaction and going into anaphylactic shock and have swelling of their airways, and we're going to lose their airways. So we may need to intubate them for that as well. Oh, let me go back one. Little note at the bottom, verification of your ET tube. So once we intubate somebody, number one, that is not the job of me as the nurse. A respiratory therapist or a healthcare provider will come in and intubate that patient, but we do need to verify that ET tube. As a nurse, I can do this. Other people, respiratory is going to do this. Everybody does this, so we can all work together. So it's a step-by-step process. The first thing you do is you look for equal rise and fall. Once you intubate somebody, we will use the AMBU bag or a BVM bag valve mask, BVM, and bag the patient. And as I squeeze the bag, I expect to see their chest rise and fall. I should see equal rise and fall, because if I see only the right side rising and not the left, that ET tube may be too far down and it went down the right main stem bronchus, and we need to pull it back. I'm going to listen for breath sounds. I should hear breath sounds in both lungs. Same thing, if it goes too far down the right, I might not hear it in the left. But I expect equal rise and fall, and I expect to hear breath sounds on both sides. Fundamentally, whoever intubates, we know how far to put that in where we are not having those problems. Then I'm going to auscultate over the epigastric area, because I should hear nothing. If I hear breath sounds there when they bag and I don't have breath sounds, but I hear sounds over the epigastrum, then that tube went down their esophagus and not their trachea. So that's the third thing I'm going to do. And then lastly, I'm going to get a chest x-ray which verifies where this is. But I'm not going to wait for a chest x-ray before I go, you know what, I don't have equal rise and fall. In fact, I don't even have good breath sounds, but I do have sounds over the epigastrum. I'm not going to wait for a chest x-ray to tell me that's in the wrong spot because my patient's getting hypoxic. So you're going to look for equal rise and fall. You're going to auscultate the breath sounds. Then you're going to auscultate over the epigastric area. You shouldn't hear anything. And then you're going to get a chest x-ray. What we also do is use this, which is a CO2 detector, which will color change. So as soon as they intubate, they put that on. They give them a couple of breaths. I should see a color change, which means I'm in the trachea and not the esophagus. So they will use a CO2 detector. So that is what a CO2 detector looks like. All right, so let's talk about endotracheal suctioning. You have a nice JPEG in your notes to show you what that looks like. There is actually a little video that you can watch on how to do this. We need to go down and suction a patient when they have lots of secretions. So a patient who's intubated will be able to cough up their own secretions, but they will be inside the tube and we need to get them out. We do not routinely suction patients. We don't go, oh, it's been 4 hours, let's suction the patient. We only suction the patient when they need it. And how do we know when they need it? We see secretions in that tube. We have lots of coughing. We have presence of rhonchi. My O2 sats may be going down. I could see other changes in vital signs. Dyspnea, restlessness, increased P peak, which is going to make sense, or I could be getting high pressure alarms. So when we suction for 10 to 15 seconds. We do use a closed suction catheter. This is a sterile procedure. You do need to wear gloves. We are using inline suction, which is a covered sterile catheter, but you still should wear gloves. If you are suctioning somebody that has a trach, not connected to a ventilator, then we will be doing sterile suctioning with a sterile suction kit, and we will do a clean hand, dirty hand, and we need to know how to do that. When we suction, we only suction for 10 to 15 seconds. We do hyperoxygenate them with 100% oxygen. There's a button on the ventilator. It's like the only button on a vent you can ever touch, and that the button initiates the breaths for hyperoxygenation, and they get it for a 2-minute time period, which means they get hyperoxygenated before, during, and after suctioning. Now, suctioning is good. You need to tell your patient what you're doing because it feels like you're sucking all the air out of them. You should talk to these people because just because they're sedated does not mean that they're asleep. Talk to them. Tell them what you're doing. So we do need to suction when it's appropriate, but we don't need to do it when it's not appropriate because there are complications. They can have hypoxemia. They can have airway trauma. They can develop an infection. We can have increased intracranial pressure. So more pressure in the thoracic cavity means more pressure up in the brain. And if you're dealing with somebody with a traumatic brain injury, we certainly don't want to suction them abnormally. Inappropriately, we only want to suction them 2 times because it will lead to increased intracranial pressure. And we don't put anything down when we suction these patients. If the secretions are thick, then we need to give them breathing treatments and we need to increase their fluid. Okay, so now let's talk about some basic vent settings. So the first one is what's called the FiO2, the fraction of inspired oxygen. So this is just how much oxygen we are giving them. So we're going to translate that to something that we know. We know room air is 21% and I can go up to 100%. Is staying on 100% for a long time good? No, we do have complications with that, but if you can't breathe and you are having hypoxia, I'm going to put you on 100%. Okay? So that's the FiO2. The tidal volume, which is abbreviated VT, is the amount of air delivered with each breath. And really we have an inspiratory tidal volume, so take a deep breath in. That's your tidal volume, and then exhale. That's your expiratory tidal volume. So we may or may not set a tidal volume for them. We're going to set a rate. That's how many breaths the vent's going to give them. So we have a preset rate. So the vent is set at 16. What that means is my patient will have at least 16 breaths a minute. Can they have 20 breaths a minute? Yes, they can, because they can breathe over the vent. So if my vent is set at a rate of 16 and my patient is breathing 20, then I know that my patient is taking 4 spontaneous breaths every minute. But never, ever, ever should the patient have a respiratory rate on the vent less than their vent set rate. They can never breathe less than the set rate. And then we have what's called PEEP, positive end expiratory pressure, or PEEP. This is the treatment for ARDS. And what PEEP does is it's extra pressure to keep the alveoli open just a little longer, because when my alveoli are open, I get better gas exchange. So the range of PEEP we can set is from 5 to 20. Optimal PEEP, or PEEP that's not concerning in a normal setting, is from 5 to 8. What we do with PEEP is we add it to decrease high FiO2s, and it is the treatment for ARDS because ARDS is refractory to oxygen therapy. So let me give you an example. If I have a patient who has ARDS and they are intubated and they have an FiO2, their amount of oxygen is 85, 90, 95. Could I go to 100%? Sure. But when I get the next gas and they're no better, what am I going to do? I've maxed out their oxygen. So when they're at those higher levels, what we're going to do is increase their PEEP to help with that oxygenation. So PEEP is the treatment. Now, we do have some complications from PEEP, adverse effects, better term than complications. It increases interthoracic pressure. When I have increased interthoracic pressure, I can have some decrease in what's called cardiac output, the amount of blood that comes out per minute out of my heart, because I've got everything in my lungs, all that space taken up by my alveoli who are being held open a little bit longer. Certainly increase pressure in the lungs gives me increased pressure in the brain, so those can be some side effects as well. But not having PEEP and having hypoxemia or a patient who dies is even worse. We could have barotrauma if we go up too high, which is why we do have a setting up to 20 that fundamentally we just kind of blow out their alveoli. And we can have decreased renal function because of the decreased cardiac output. So these are settings: FiO2, tidal volume, rate, and PEEP. We're going to look at a vent screen. When you take care of a patient who is intubated, you're going to go and look to see what these vent settings are. Now we have two more things we're going to look at, and this is called patient data. So we've talked a couple of times about what's called peak inspiratory pressure, or it's P-peak on a ventilator. What P-peak is, and this is so important in ARDS, it's the maximum pressure that occurs during inspiration. So what the vent does is it's measuring how much pressure it's taking to push a breath into those lungs. What it's telling us is the compliance of the lungs and how much resistance is in that airway. And remember, in ARDS, the lungs become stiff, so what we see is increasing P-peak. An increased P-peak could be the first sign of ARDS that you see. Okay, you got to think about that one. Now, there's a couple of reasons P-peak can occur outside of ARDS. If your patient has a lot of secretions and they're coughing, do they have increased airway resistance? Is it harder to push a breath in? Yeah, because they're coughing and there's lots of secretions. So we suction them and their pee peak goes down. If your patient bites their ET tube with their teeth, do I have increased resistance? Is it harder to push a breath in? I do. When they quit biting, their pee peak goes down. But when that pee peak gradually goes up during your shift, you need to start suspecting ARDS. Now, pee peak doesn't have a specific range. It is patient specific, but typically it's 20 or less. So we're going to say you came onto your shift and your pee peak's 18. At 11 o'clock, you look over and you're like, my pee peak's 21 now. And you look at your patient, they're not biting, they don't need to be suctioned. You're like, And at 1 o'clock, you're like, wait a minute, my pee peak is 25. And you're like, there's no reason it should be 25. You're seeing a gradual increase in pee peak, and those lungs are getting stiff, losing compliance, and your patient is probably developing ARDS. The last patient data is this total respiratory rate, which we talked about. So on our ventilators, it tells us the total respiratory rate, and it's never wrong. So it's like a cheater method. If your instructor comes in and says, hey, what's your patient's respiratory rate? You can look on the vent and read it. And that total respiratory rate is the rate set by the ventilator. If there's a rate set, sometimes there's not a rate set, the patient's breathing spontaneously, plus their spontaneous breath. So a total respiratory rate would be the vent set rate plus any spontaneous breaths. So let's just kind of look at a vent screen and see what this looks like. You do have something that's called a mode, which is over here, which is how we're delivering the breath. So you want to know about that? Ask your nurse, talk to respiratory therapy. You might have a tidal volume and you may not have a tidal volume. That's just how big a breath that they have. We're going to look for the FiO2, we're going to look at the respiratory rate, and we're going to look at the PEEP. So here's my mode here, and I have a PEEP here, and here's my PEEP, and I have an FiO2, I think that PEEP's 5, and then I have an FiO2 of 21%, which is room air, which makes me think, I wonder why this patient's intubated. This is a demo screen. And then I'm coming over here, and here's my P peak. And then right here, because it says B/M for breaths per minute, that's how fast my patient is breathing. It will also tell me their expired tidal volume over here as well. So vent settings, I always say go look for your oxygen. That's where your vent settings are. And then look for your patient data. So that just kind of gives you an example of what a vent screen looks like. Now, we may have vent alarms. Number one, we are never going to disable and turn off alarms. You may see nurses silence an alarm, but they are not turning them off. Turning them off, which is, that's like turning your alarm off instead of hitting snooze. Silencing an alarm would be like hitting a snooze. You could get a volume alarm, which just says that they're not taking enough tidal volume, so they may need to breathe deeper. You could get a high pressure alarm. That means it's picking up high pressure, so high P peak, because there are parameters that respiratory sets. So you need to go see what that is. Are they biting the tube? Do they need to be suctioned? A low pressure probably means that they've become disconnected from the alarm, from the vent. Now, if you get a vent alarm, you get up and you walk in the room, and the first thing you should look at is you should look at that patient, and you should, number one, see, is the ET tube still in? Is it connected? And what does my patient look like? Look at your vents, see what alarm is, and then look at your monitor, see, are you having an O2 sat issue? What's your respiratory rate, your blood pressure, your rhythm, and all of those kinds of things. If you get an apnea alarm, then your patient isn't breathing on their own. So if we're trying to wean them and get them off, we may need to wake them up, tell them to take some breaths. And if there's an alarm and I can't figure out what it is, or my patient's in distress, you need to take them off the vent and bag them and call respiratory. All right, we got a couple more slides. This is just a little bit long. longer than I like, but I think we'll get wrapped up in just a few minutes. So, complications from mechanical ventilation. The number one thing that we need to worry about is ventilator-associated pneumonia, VAP. So, we're going to talk about that. We've talked about barotrauma. Unplanned extubation. The patient reaches up, rips that ET tube out. Can take their vocal cords with them, give lots of damage, and certainly if they still need to have help breathing, then we're in a real problem. So, we need to make sure that that doesn't happen. They could have some aspiration. So we need to watch for that, which is why we set the head of the bed up. After extubation, they may have swallowing difficulty. So if they've been intubated more than 24 hours, they need to have a swallow evaluation before we give them anything. They can have some cardiovascular compromises. They can have some GI effects as well. But those are not very common. And we'll talk about ways to help prevent those. All right, so let's talk about VAP, because I always say, you know what, you need to learn VAP because it's probably going to be on the NCLEX, and I've had students come back and go, yeah, you're right. So ventilator-associated pneumonia, VAP. Prevention is key. We need to do everything we can to prevent this. This is a nosocomial infection. So what do we need to do? We need to do hand hygiene. We need to do universal precautions. We need to prevent transmission of microorganisms, so we need to have aseptic technique when we're suctioning. So wear some gloves, use that inline suction catheter. We need to modify any risk they have for infection. So prevent aspiration and fundamentally keep them off the vent. If they're not intubated, they don't develop VAP. And what VAP is an infection that has occurred 24 hours or longer after being intubated and can occur up to a couple of days after intubation. So there is specific criteria. Treatment is antibiotics. And what are we going to do? We are going to do the VAP bundle. So here's our VAP bundle, and I would encourage you to put a big star next to this and make sure that you know this. So what do? We keep their head of bed at least 30 degrees. I like to say 30 to 45 degrees. We need to assess readiness to wean. We need to do spontaneous awakening trials, spontaneous breathing trials. That is spontaneous awakening trials. We really shouldn't have to turn sedation down to do that, but sometimes that happens. We need them to wake up, follow commands. Spontaneous breathing trial. Respiratory is going to come in, make some vent changes, and allow that patient to take more control of their breathing and see how they are doing. So SATs and SBTs really should be done every day unless there's reasons that we don't do that. We need to do prophylaxis for VTE or DVT. I see that my slide actually should say VTE and it says DVT. Enoxaparin is pretty common. We could have SCDs. Prophylaxis for stress ulcers. So currently we are giving it just lost my head. Tagamet, I believe, is what we are currently giving. We have switched in recent years from what we were giving to newer medications that are showing better results. And we need to do routine oral care with chlorhexidine. Routine oral care is minimally oral care every 4 hours, and we do that chlorhexidine every 12 hours. So you need to know this. This is infection prevention. That bundle is really important. Part of our strategies as well beyond the VAP bundle is doing things like early mobilization, because the sooner we can get them up and move them, the quicker they're going to come off the vent. And that is part of the ICU liberation bundle, and you have some information on that. That is to help prevent complications from mechanical ventilation, preventing VAP, also preventing delirium. This is an ICU specific piece, but the items listed in that for you about delirium are not just ICU specific, because patients on the floor develop delirium, and patients who develop delirium have more complications. Specific to ICU, those patients who develop delirium have an increase in mortality by 50% for up to 6 months after they're there. So it's important that we use this ICU liberation bundle and try to prevent these things. And early mobilization could mean walking a patient on a ventilator. Okay, so let's talk about weaning from mechanical ventilation, because we're going to do this because our goal is to get them off. So the patient needs to assume part or all of their work of breathing. So we'll start with them doing some, and then they need to do all. So this is why we're going to do our spontaneous breathing trials. We certainly should have already done a spontaneous awakening trial. We need to assess baseline parameters like respiratory, cardiac, neuro assessments, vital signs, rhythm, pulse ox, maybe ABGs, and we need to make sure that those are fairly stable. We shouldn't have any increase need for cardiac or respiratory support. If your patient, maybe your healthcare provider comes around and says, you know what, let's try to wean this patient today, and your patient's on a vasoactive medication that we have had to titrate up, that patient doesn't need to be weaned. We have a cardiovascular issue that we're dealing with. If they have developed a fever that they didn't have, then we need to deal with that before we wean them. We need to make sure that they don't have any new problem. And fundamentally, the problem that they were intubated for is better, or better yet, resolved. Weaning stopped when this patient becomes unstable. And there's lots of ways this patient can become unstable. We're going to look at respiratory distress, cardiovascular instability, so changes in vital signs, whether they go up or go down. They have dysrhythmias, they have fatigue, other signs of distress. Respiratory is going to come, start them weaning, and then they leave, and we are left with these patients. So we do need to watch for this, and if they are not tolerating weaning, we need to call respiratory and tell them to come back and put them back on a vent, turn it back on. We haven't taken the tube out, but turn it back on because they are not tolerating that. We could be doing terminal weaning, which comes from your book, which is withdrawing ventilator support. If that is a decision that the patient has told us they want, or has given us paperwork to say that they want, and or the family has come to this conclusion that we need to do terminal weaning, and we need to provide emotional support for the patient and for the family. We give them pain medications so that they are not in distress as we do a terminal wean. All right, so I hope that that answers your questions about mechanical ventilation. Sorry for the long recording here, but it's just a lot of stuff to talk about. Thank you.